So, good evening, respected seniors, dear colleagues, and my dear students. So, it gives me immense pleasure to welcome you all in the Heartline, the Voices of Cardiac Anesthesia, which is an academic initiative from West Bengal IACTA. So, after a wonderful beginning with our first episode of Foundations of Transesophageal Echocardiography, today we'll move to a step deeper, that is, into the very structure that defines the cardiac function and guide our intraoperative decisions, the heart valves. Today we'll be learning about the mitral valve and its the echocardiography importance. So the valves are not just anatomical structures. It visualization of the valves on echocardiography. They are a dynamic living structures and every valve tells a story. A story of pressure, flow, adaptation, and sometimes the pathology that has been missed in the transthoracic echocardiography. So, in clinical practice, especially in cardiac anesthesia, our ability to quickly recognize the valve morphology, its motion, the dysfunction, this can significantly influence the surgical planning and the perioperative outcome. So that today's session, the valves, the mitral valve, and the basic pathology, what to look for, is designed to simplify this approach, to train our eyes not just to see, but to interpret with clarity and confidence. So we truly fortunate to have with us Dr. Abhinandan Mondal, a consultant in Apollo Multispecialty Hospital, who is a wonderful teacher and is a specialist in transesophageal echocardiography, who will guide us through our essential yet challenging aspects of TE with his clarity and clinical insight that we have evidenced in our last class. I'm confident that after today's session, we can strengthen our fundamentals, but also we can enhance our day-to-day echocardiographic decision making. So thank you for joining with us in this evening. Without any further delay, I invite Dr. Abhinandan. Please begin our today's session. Thank you very much.
Thank you, ma'am. Thank you for your kind introduction. And hello, everyone. Today we'll be discussing about valves on basic pathology series. We'll be discussing on mitral valve. I am just dividing this topic into mitral and aortic and tricuspid because it's a mitral valve is lot to discuss for within half an hour. So in mitral valve, we have to know the brief anatomy. I will not be boring you all with many theoretical things, but I'll be teaching you only which is relevant and which is must to know while you do transcatheter echocardiography in cardiac surgery. So if we see from your on the base of the heart, just hold on, I'm starting on a laser pointer. If we see from your base of the heart, we can see that this is your mitral valve, which is your posterior and left structure, and here is the tricuspid, which is your posterior and the right structure, and here this is your aortic valve, and the most anterior structure is your pulmonary valve. So this is your open during your diastole, and this is during your systole. So if we focus on mitral valve anatomy, if this is your aortic valve, you can see that there is a non-coronary sinus and left coronary sinus, and this is your mitral valve. In between, this is one of the most important thing that surgeons are very much aware of while putting the valve, which is the aortomitral curtain. So this is the structure they don't want to intervene or they don't want to injure while putting the valve. So you have to be very much sure which part is your aortomitral curtain and where from the mitral valve actually begins. So there are very important structure around mitral valve which will be I will be discussing more. You can see that this is the circumflex artery that goes around your left side and goes around in the posterior along with your coronary sinus. So this circumflex artery, it is is very prone for injury while putting the mitral valve. So after putting the mitral valve also, we'll have to see whether there is any flow acceleration in the circumflex artery, or if there is any regional valve motion abnormality, new onset, so that we can tell surgeon that there is might be an injury due to circumflex artery. And there is also bundle of his that you can see over here, that is also near your posterior medial commissure. So what are the thing that you should know? That this is a mitral valve in your closed position, and this is your open position. So this is your in diastole, this is in your systole. So you have to understand, you can appreciate that there is a gross change in your annular sizing during your diastole and systole. So you can see that there is a anterior posterior diameter, this is your commissural diameter. So this commissural diameter actually remains the same, whereas your anterior posterior diameter, it increases during your diastole. So this entire this area becomes at least 25% more during diastole. So this is a importance, very, very much importance while we decide whether the patient is having any annular dilatation or not. So we can decide upon that. So in by going into the mitral valve, there is an anterior leaflet and there is a posterior mitral leaflet. So this is your posterior mitral leaflet, this is your anterior leaflet. So you can see that the anterior leaflet, for circumference, it is around 1/3 of your mitral valve, and it is 2/3 is covered by your posterior leaflet. But you can see that the anterior leaflet is much wider, whereas your posterior leaflet is much narrow. So the main the important thing that you have to remember, though it looks very much like that your anterior leaflet takes away most of the surface area, but it is actually the both the leaflets actually share the almost equal surface area. So actually posterior mitral leaflet, it is actually divided by your three scallops, by your three indentations. By two indentation, that is by P1, P2, and P3. There is no indentation in your anterior leaflet, but we can according to your Carpenter's classification, we can do a nomenclature of your A1, A2, and A3 with the corresponding posterior mitral leaflet scallops. And you can see that this is your anterior lateral commissure, this is your posterior medial commissure. So mitral valve is not like this as we see over here. I'll be discussing in your next slides. So there are multiple types of chordae that we can discuss over here. You can see that this is your primary chordae, which originates from your papillary muscle tip, and it ends in your tip of your leaflet. And if there is a secondary chordae as well, which actually attach on the under surface of your mitral valve leaflet, and is a basal which actually ends up at your base of your leaflet. And it many times it is not shown in the picture. It is originated from your myocardium rather than your papillary muscle. So this is your anterior leaflet. If we cut open the mitral valve, it is a picture taken from your Carpenter's book. So this is if we cut open the mitral valve leaflet, so it is an anterior leaflet and this is a posterior leaflet. And this shaded area that you can see over here, this is your coaptation zone. This coaptation zone at least should be 5 millimeter so that the valve coapts well. So in between, you can see there is a commissures also. And you can appreciate also in the both the anterior leaflet and posterior leaflet, there is the area in between which are actually free of any chordae. Now, this is a very important concept you have to understand. Our mitral valve is not actually a proper circle valve. So it is actually a saddle-shaped valve. So saddle-shaped means it has a topmost portion and it has a lowestmost portion. The topmost portion is actually what we see over here. So this is from your aortic valve area up to this is your anteroposterior axis. So this anteroposterior axis that we see in a mid-esophageal long axis view, that gives your anteroposterior axis diameter, and which is the shorter diameter. This is the shorter diameter. And the intercommissural diameter that we see in the mid-esophageal commissural view, that will be your longer diameter. So whenever any surgeon asks you what is what is the uh, uh, mm, sorry, what is the annular diameter of your mitral valve, then you have to tell the two diameters also at the mediasophageal commissural view and also mediasophageal long axis view. So we have to remember the blood supply of our papillary muscle. That anterior papillary muscle actually receives blood supply from three sources: your branch of a circumflex artery, and a branch of your left anterior descending artery, a branch of your diagonal artery. Whereas your posterior papillary muscle, posterior medial papillary muscle, it actually receives the blood supply from only a single supply, which is a branch of posterior descending artery. So therefore, this posterior medial papillary muscle is actually more prone for injury and also more prone for ischemia. So if there is any ischemia in this artery, so there will be a residual valve motion abnormality, and also the posterior medial papillary muscle avulsion and also its ischemia and infarction is much more common than your anterior papillary muscle. So these are the six views that we have to be very much aware of while we discuss and while we tell anything about your mitral valve. So the number one is the mediasophageal fourth chamber, that is your 0 degree to 20 degree at about mid 30 to 35 centimeter of depth of your that we have already discussed in our previous class. Number two is the mediasophageal commissural view. So this is your uh, this is your mediasophageal fourth chamber view, the C, and mediasophageal commissural view, that is the photo number D. So here we can see there is a mediasophageal commissural view at around 40 to 60 degree, and at around 90 degree we can see about mediasophageal two chamber view, and you can appreciate the different types of scallops. We'll be discussing more details in the upcoming slides. The scallops gets changed in your every image. So this is your mediasophageal two chamber, and this is your mediasophageal long axis view. So this is mediasophageal long axis view, where you can appreciate there is a A2 and P2, and also A2 and P2 you can see the in the image of your mediasophageal fourth chamber view. But the orientation of your scallops becomes opposite. So you have to be very much careful that in the left side of image, you can see that this is your left side of image gives your anterior mitral leaflet, and right side of your image gives your posterior uh, mitral leaflet. Whereas in your transitional view, from this view onward, your left side of the screen gives you your posterior mitral leaflet, and also your right side of the image gives you more of a anterior mitral leaflet. And also this is your transgastric visual short axis view. It gives you a en-face view of your entire mitral leaflet. We can do a planimetry over of your mitral valve, and also we can see all the scallops over here and all the six scallops as per Carpentier classification. And this is a very important view of transgastric two chamber view. Whenever you have to comment on any subvalvular apparatus, you have to remember in these all these views, the it is actually perpendicular. It is actually parallel to uh, your uh, echo that is for your echo, and whereas it is perpendicular uh, for your. So that is why you can see the structures much better in this view. It is a transgastric two chamber view. Where whenever you this transgastric two chamber view, you have to just go deeper from your transgastric basal short axis view, so that you can get a mid papillary short axis view, and you just change the omniplane angle to 90 degree to see this view. So in this view, the echocardiography, your actually gives you a better understanding of your papillary muscle, and also if there is any calcification of your cords. So this is your and also important thing that I have missed in the previous slide. So this is your anatomical view, this is your TOE view, and this is your surgical view. That you have to understand. This is an anatomical view means that valve actually remains like this only. So this is your anterolateral commissure, this is your posteromedial commissure, and it's named accordingly. But in the TEO view, it is just the opposite of your what you see in the what is the actual thing on the anatomy, because you are seeing it from behind. And also surgical view, this is the view what surgeons actually see while from the left atrium while standing from the right side of the patient. So this is a atrial view on the surgeon's view. So if it is a mediastinal four chamber view, if you see in a neutral position, you can see that you can appreciate what are the leaflets that it actually cuts. And if you antiflex, we can see you can actually see other scallops also, and you can retroflex, you can see the A3P3. So if you antiflex, you can see A1P1. If you keep it neutral, you can see A2P2, and if you retroflex, you can see A3P3. And in the mid-cerebral commissional view, you can see your P1, A2, and your P3. It is cut over like this. So this is a ventricular view that I have already discussed you. Whenever you see antiflex from your mediastinal four chamber view, you get the five chamber view, and you also can see A1 and P1. If you go to the four chamber view, you can see A2 and P2, and if you further retroflex or go down, you can see the A3 P3. Whereas in the 60-degree, you can see there is P1, A2, and P3. That is P1, A2, and P3. Whether in the image, it from the left to right, it is P3, A2, and A1, P1. So this is the mediastinal two-chamber view. While the surgeons, they can see, this is your, if the probe is neutral, if your probe is neutral, you can see that this is your A1, A2, A3, and P3. It moves like that. Hello?
Yes, you're audible. We can
Yeah.
hear you. Okay.
Okay. Just hold on a second for just a minute. Very sorry, just a minute. You can hear me? Hello? 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 Hello, can you hear me?
Audible, sir.
Okay. Thank you. So this is your ventricular view that you can see that I have already discussed. If it is this is your neutral view that where you can see your A2, A3, and P3, and A1 is also there. Whereas this is the thing that I have already mentioned, and this is if you rotate it towards your left, then you can see only your posterior leaflet, that's P1, P2, and P3. And if you rotate towards your right, you can see your more of a A2 and A3 rather than A1. And this is your view that I've already discussed in your 135-degree, that is the mediastinal long axis view. Here you will cut more in a A2 and P2 fashion. So what do you screen? I am audible, I guess. Actually, there is a problem with my microphone.
You are audible, sir.
Am I audible?
Audible, sir.
Okay. Thank you. So actually, what do you see? In a 2D examination, the leaflet, we have to see mobility, thickness, calcification, coaptation, if there is any mass, and what is the area of your mitral valve. In annulus, we have to see whether there is any, if it is dilated by seeing the diameter, and also if there is any calcification.
If there is any chamber dilatation, that is your if LA enlargement, if there is a LV enlargement, if there is any hypertrophy, or if there is any mass. In color Doppler, whether the flow is laminar and any turbulence. This is a very important. This is the thing whenever you see a valve, you put a colored Doppler, you can see, yeah, if the Nyquist limit is you keep around 50 to 70 centimeter per second, and you see whether the flow is laminar or if there is any turbulence. If there is any turbulence, that means there is any pathology. So then you have to decide what is the phase of the cycle of your cardiac cycle, whether it is due to diastole during or it during systole. Where if it is during diastole, that means you are dealing with a stenosis, and if there is any turbulence in your systole, that means you're dealing with a mitral regurgitation, and if both, then the patient has both pathology. But you have to be very much careful about the Nyquist limit that you always see. And also, if there is any formation of PISA, I'll be discussing all these things later on. And if there is any formation of any turbulence, so and also the blood is going from your LV to the LA, if there is any vena contracta. So then we put the continuous wave Doppler, where we measure VTI, mean and max spatial gradient, PHT, and deceleration time. So these are the things that we do in a mitral valve. These are the examination that you have to do in mitral valve. So depending on whether the patient is having mitral stenosis and mitral regurgitation. So if it is a MS, so what we have to see? We have to see mitral valve area. We have to see mitral valve pressure gradient. We have to see leaflet mobility, thickness, and calcification. We have to examine subvalvular apparatus, whether there is any calcification, there is any restriction, and also if there what is the size of the LA, if there is any clot in left atrial appendage or in the LA itself, if there is associated MR, if there is associated MR, which is predominant, the patient has a more predominant MS or MR pathology. And then we have to see other valvular pathology also. So for the backward pressure, if there is any RV dysfunction or associated TR. So these are the things that you have to see if there is a MS. If it is an MR, we have to see whether the jet is central, eccentric, or wall hugging. We have to see vena contracta. We have to understand why it is occurring, whether this is due to leaflet pathology or any chordae and your papillary muscle, or it is due to myocardium itself. So whether it's a that means whether it's a primary or secondary. So if there is a pathology in your mitral valve leaflet and or your chordae and or your papillary muscle, then the problem is somewhere around, it is a primary pathology of your mitral valve. If the problem is not related to the mitral valve, but rather than your myocardium, then that is a problem of your secondary MR. So that is a functional MR. So primary MR is also called degenerative MR. Secondary MR is also called functional MR. So then we have to put continuous wave Doppler. We have to see if there is a leaflet prolapse, flail, thickening, calcification. What is the effective regurgitant orifice area of the MR? What is the size of the LA? If there is an associated MS, then which is predominant, and also the subvalvular apparatus. So we have to be very much aware of this Carpentier classification of MR. It is asked in every exams. So Carpentier type 1. So Carpentier actually classified the MR by your motion of your mitral valve leaflet. So type 1 deals with your normal mobility of your mitral valve leaflet. Type 2 is your increased mobility, and type 3 is the decreased mobility. So you can see here that there are three types of pathology. There is a perforation, there is a cleft, and there is a annular dilatation. So if there is any perforation, we can see that there is a no increased motion of your leaflet. So these all the things are leaflet motion is normal. So in case of your perforation, there you can see the MR jet occurs through the perforation. If there is a cleft, that is a congenital thing. And I want to discuss another thing while we are mentioning cleft. What is the difference between cleft and your indentation? Can anybody tell me what is the difference between cleft and your indentation? First of all, always remember there is no indentation in the anterior mitral leaflet. So there is indentation, actual indentation only in your posterior mitral leaflet. So and another thing is to mention that if the indentation, that means there is a furrow, there is a groove in between your two scallops in your posterior mitral leaflet. If it is more, it covers more than 50% of your width of your leaflet, that is a cleft. If it is less than 50% or it is near about 30%, it will be better to term as a indentation. And also this is a case of annular dilatation where the leaflet mobility is normal but still the coapting abnormally, so that is why there is a MR is occurring. In your Carpenter type 2, you can see this is a flail, this is a prolapse, and this is a complex flail and prolapse. And another thing we have to terminology that we have to be very much aware of, which is billowing. So what is actually billowing? Where the tip of the leaflet, it remains lower the level of your annular plane, and also it is looking towards your left ventricle, so that is billowing, but your body of the leaflet is above the level of your mitral annulus, so that is your billowing. What is prolapse? Prolapse means the tip of the leaflet, it is at or above the level of your annulus, but your tip is still looking towards your LV, whereas in your flail, it is tip is looking towards your LA, and also it is the level of it's above the level of your annulus. So this is your flail, this is your prolapse, and this is a complex flail and prolapse. So you can appreciate, well, the direction of the MR, although in the Carpentier type 2, it is towards your unaffected leaflet. So this is a very important thing to understand. So it is not a, either it will be a wall hugging or it will be a eccentric. So these jets are actually directed towards your unaffected leaflets. So this is your Carpentier type 3. So Carpentier type 3 actually remains in type 3A and type 3B. Type 3A, there is only during diastolic restriction, whereas in type 3B, there is a systolic restriction. So in type 3A, which is a rheumatic, is a classic pathology, where there is a, the valve cannot open and it also cannot close. So there is a only diastolic restriction. There is diastolic restriction as well. So you can see that it is, if the both the leaflets are equally involved, the jet is more or less, it is central. And also you can see in this image also, the affected leaflets, the jet is actually directed towards your affected leaflets. So in a Carpentier type 2, it is directed towards your unaffected leaflets, and this is your more towards your affected leaflets. You can see there is an asymmetric systolic restriction in this image. You can see even better. There is an inferior infarction has occurred. So this leaflet has become restricted. So it is the MR is directed towards your ipsilateral side. So this is your 2D examination. So at first you will have to appreciate. I'll show you many images and videos right now from onward, so that you can understand what you actually have to see. So this is a 4-chamber image. You can see 4-chamber loop. You can see, appreciate, there is a thickening of your leaflet, of your anterior mitral leaflet. You can appreciate that. And also in this image, you can see there is a calcification of your tip, more of a anterior mitral leaflet. There is a tip calcification. Also, there is a calcification in the annulus also. So whenever you comment on any calcification, what you do, you decrease your gain settings of your echocardiographic machine. So whatever machine you are using, you would just decrease the gain of your 2D, and you can undermine the other myocardial structure which is not yet calcified. And you can see that in the calcified area will still glow a brighter one. So while commenting on, you have to decrease the gain and you have to see the calcification. Now you can see the mobility. So in this image, in this loop, you can see the mobility is restricted. Whereas why it is restricted? It shows that the tip mobility is restricted. You can see, appreciate over that, but the body of the leaflet is hypermobile, giving a typical hockey stick appearance of your mitral stenosis that you can appreciate over here. And also, this is your type 3B. But this, in this image, you can see the mobility, the leaflet is actually, there is a prolapse over you. You can see over here. So it is a increased mobility. So this is a Carpentier type 2. And here you can see, yeah, here you can see there is a coaptation defect. Now the Wilkins score, this is the score that was previously used, but it is still being asked in many examinations. So be very much aware of this Wilkins score. What are the things that you have to remember? That what are the things we see? We have to see mobility, we have to see subvalvular thickening, we have to see thickening of the leaflets, and we have to see calcification. So by this thing, these leaflets has been classified by this grade. So if grade 1, grade 2, grade 3, and grade 4, for all these four things, the maximum Wilkins score possible is 16, and if the value is less than 8, that means the valve is more pliable and you can go for your BMs or your BMV. If it is more than 12, then it is better. If you don't do a BMV, you have to go for a mitral valve replacement. And 8 to 12, it is a score. You have to remember that these are the things where it is the decision to be taken as an individualized basis, whether the patient to be taken for BMV or mitral valve replacement. So mitral valve area measurements methods. So yeah, I have mentioned 6 methods, but I have specifically mentioned Gauldin formula over here, and it is little different and a little distant from your all these three, because all these five, because you have to remember this Gauldin formula, it is actually a catheter based formula. So this formula is actually not done by echocardiographically. So that is why I will not discuss over here. So Gauldin formula I will be discussing more in a aortic pathology. So, Gauldin formula, we can also measure mitral valve area. So these 5 methods are the mitral valve area measurement methods. So by the gold standard is your planimetry. The planimetry, there are 2 methods, whether it's a 2D or a 3D. Currently the 3D planimetry, it is the gold standard for your mitral valve area measurement. And other thing you can remember is a pressure half time from the deceleration time, from your continuity equation, and your PISA method. Continuity equation states that whatever blood is going through the mitral valve, it's also going through the LVOT, and if the blood is going through the mitral valve, is also going through the RVOT. So MVA planimetry, where it has been done in a 2D examination, it is a midesophageal short axis, midesophageal basal short axis view. Very sorry. There's transgastric basal short axis view, where you freeze the image in the lowest possible area, where you can see the entire mitral valve area tip, where you can do a planimetry. But you have to remember why it becomes very much fallacious right now, because you don't know which of the area of the leaflet is actually calcified, and the calcification is also not symmetrical throughout the valve. So many a times you can see, or you will not be able to see the entire tip of the leaflet. And if you also can see the entire area of the entire circumference of your leaflet, that also will not tell you whether that is the tip or whether that is the narrowest area of your valve. So right now the gold standard is your 3D planimetry, which is being done by multiplanar reconstruction. So this is a multiplanar reconstruction. You can see over there. So this is your LA LV, and you can just rotate this image, and it is a framed image. I'll be discussing more in this when I will be taking your 3D classes. So in your multiplane reconstruction, you actually can rotate, and you can actually crop the image accordingly in your from your entire 3D data set. So this is your one view, and this is your another view, just the cross section through that. You can see, appreciate over this blue line is also over here only. This is your long axis view. You can see over your aortic valve, and this is just your orthogonal image. So this is your orthogonal image. So you have to go through your leaflet tips. This blue line will go through the leaflet tips. That will give you this image. So you can do a planimetry and you will be very much sure whether you are dealing with your tip from your mitral valve leaflet. So colored Doppler, what we actually see is the flow acceleration. So while dealing with any flow acceleration, always keep an eye over these numbers. So this is your Nyquist limit. So Nyquist limit, what the Nyquist limit that you are seeing, what you are dealing with. So you can see this image, the patient is having severe MR and also severe TR. So this is a flow acceleration that you will be able to see. And there is a formation of PISA as well. You can see, appreciate over here, both in the RV side and both your LV side. And there is a formation of PISA because the blood is going from your LV to LA and RV to RA. And you can appreciate the PISA always forms in the preceding chamber whenever there is a problem. So if there is any PISA formation in a MS, it will be formed in a LA side. And if there is any PISA formation in your MR, it will be formed in the LV side. So that you will have to remember, that you have to be very much aware where which PISA, which pathology has PISA in which side of the chamber. So flow acceleration actually tells you or gives you a first glance whether the patient is having a stenosis or regurgitation. You have to look for any PISA formation for MS or MR. You have to see for any vena contracta, which is exclusive for MR. Just do remember, there is no vena contracta in MS. So vena contracta is specific for your MR and or any regurgitation. So vena contracta is the narrowest portion. I'll be discussing more over the upcoming slides. And what is the type of MR, whether it's a central, eccentric, and wall hugging. So in this image, you can see this is a eccentric image. And also you can also tell that this is also a wall hugging because you cannot appreciate any gap between your jet and your wall of your left atrium. So that is how we can tell. If there is any gap, you can appreciate over here. So that is, but still it is not central. That we tell it about. It is an eccentric jet. If it is moves towards your roof of the LA, that means it is a central jet. If it is there is no gap you can see over here. It is more of it is going hugging the wall. So that is a wall hugging jet. So if you see any wall hugging jet, uh, at a first glance, it has to be considered as a severe unless proved otherwise. So this is a PISA formation. So this is a PISA formation. We can see, and I'll discuss the physiology further. So this is a PISA formation, and we can appreciate suddenly there is a change in color. The change in color from the red, it is a formation of, suddenly it is changed to cyan color. So this is the radius has been taken from your orifice, exact site of the leaflet up to the change of color from cyan to yellow. So this is a PISA radius. And also we can appreciate if we do a MR-VTI, and if we do MR maximum velocity, we can give a maximum PG of 68.3 millimeter of mercury. And from MR VTI, we can this, if we put a continuous wave Doppler of this jet, we can get this kind of tongue-like waveform. And also it is a complete waveform, you can see. So you can appreciate this is a severe MR. And by putting the VTI, you can appreciate, you will get the complete MR-VTI of 128 centimeter. So what is the importance that I'll be discussing in the next? So whenever blood actually flows from any chamber towards a narrow orifice, its actually speed increases. So whenever the speed increases, at first speed keeps on increasing, and it comes at a certain point where the speed crosses your Nyquist limit. Then you cannot determine, rather the machine cannot determine whether the blood is going towards the probe or it is away from the probe. So that is why this change of color of this forms a this is a isosurface, has a RBCs with a particular speed of your Nyquist limit. So blood flow converges proximal to the circular orifice. So gradually assumes the shape of a hemisphere with equal velocity within each layer. So this is the MR jet. So there is a PISA formation on your LV side. So area of the PISA, you have to we can know, if we know the radius, we can know the formula, the 2 into pi into r PISA square. Then flow to the PISA, it is the area PISA into the aliasing velocity, that means your Nyquist limit. And if we want to know what is the flow through the MR, then we can know that if the flow through the MR orifice, it is also through the flow through the PISA. So EROA, which is our actual, we want to know this one, into Vmax of the mitral regurgitation. So this gives your Vmax. So Vmax is equal to area PISA into V aliasing. So from this formula, you can actually determine how the EROA mitral regurgitation comes into play. So this is a vena contracta that you can also see over here. This is the narrowest portion of your jet. So this is a vena contracta width from your 2D examination. And this is the image of your 3D examination, just like your MPR that has been done. I have already told you earlier. Here from we can actually know the vena contracta area. So vena contracta area is better than your vena contracta width. So this is a 3D method. So you can see there are multiple images of your Doppler. So what are the basic things? This is actually normal. The first image is actually normal transmitral flow velocity. You can appreciate over here. The first thing is different is that you are putting pulse wave Doppler over here. So whenever there is any turbulence, you do not put pulse wave Doppler, you put continuous wave Doppler. So whenever you put continuous wave Doppler, it looks like this. And also if there is any pulse wave Doppler, it looks like this. So, but if you put pulse wave Doppler in your any turbulence, you will not be able to see any particular waveform in a particular direction. So because the machine cannot decide from this pulse wave, because pulse wave Doppler is only for a laminar flow. If there is a laminar flow and the flow velocity is less than 1.3 meter per second, then only your pulse wave Doppler can pick it up. But if it is if it is more than that, you are seeing any aliasing, then that means you have to put continuous wave Doppler. You can appreciate over here, this is a flow of your MS and this is a flow of your MR. So in your MS and MR, you can also appreciate over here, in this patient, there is a different sizes of your inflow waveform. So why it is occurring? Because the patient is also having atrial fibrillation. And also you cannot see any proper A waveform because there is no proper atrial contraction as well, because the patient is also in AF. So by putting, I'll be discussing this thing in further, that how you can actually determine your mitral valve area. There is a formula of mitral valve area that is a 220 divided by PhD that will give you a mitral valve area. And also there is a formation of your, if you put a VTI over entire waveform, and if you trace the entire waveform, you can get a VTI, and also you can get the mean pressure gradient. So mean pressure gradient is also your determining factor for your, whether it's you're dealing with a severe MS or mild MS or moderate MS. And also you can see over here, this is your pressure half time method. So what is the current guideline of stages of MS? So this is a, if the area is less than equal to 1.5 centimeter square mitral valve area, and diastolic pressure half time, it is, if it is more than equal to 150 milliseconds, that means it is a, you are dealing with a severe MS. So mitral stenosis echocardiographic grading, that these things, this is the chart that you will have to keep remember, that in mitral valve area, if it is more than 2.5, it is currently called as a mild MS. If it is moderate, that means it's 2.5 to 1.6. It is severe, it is if it is less than equal to 1.5. In case of pressure half time, if it is less than 100, it is mild. It is 100 to 149, it is moderate, and if more than equal to 150, it is severe. Mean gradient, I have put it as star, because always remember the mean gradient is actually, it is currently, it is not considered as a determining factor whether the patient is having severe MS or not, because it is also very much rate dependent or flow dependent. If the patient is also having concomitant severe MR, that patient also might show you a increased gradient in spite of the patient is having mild MS. So always you have to remember, while putting the mean gradient, you have to tell whether the patient is having, what is the heart rate that you are dealing with. But anyway, if mean gradient is more than equal to 10, then that means you are dealing, probably you're dealing with a severe MS. And also systolic pulmonary artery pressure, that you can determine from your TR velocity, that I will discuss in our next class, that in the systolic pulmonary artery pressure, if it is more than equal to 50, that means it is you are dealing with a severe MS. So what is your normal mitral valve waveform? That is your mm, spectral Doppler waveform. So if you put a waveform, you can see that this is a E wave, and there is a distinct gap in between this, because this is a period of diastasis, and also this is a wave. So these are peak wave, these are A wave distance, and this is a deceleration time. Deceleration time means when the E wave becomes it is extrapolated to baseline. So it is the time required is called deceleration time. So mitral valve area, there is another formula by deceleration time. If you divide the 759 by deceleration time, you will get a mitral valve area. And in a case of stenotic mitral valve, you can appreciate there is no diastasis also. And there is you can see the peak also decreases, and also the pressure becomes equal much later on. So it takes more time to get the pressure equalized from your LA to LV. So in case of stenotic mitral valve, so if we extrapolate from this area, so this is your deceleration time, and also this, if we extrapolate this thing, so it will give you a pressure half time. So this pressure half, the time at which this pressure becomes half, it will give you the pressure half time by your echocardiographic machine. If you divide it by from 220, it will give you a mitral valve area. So from this onward, I will be showing you multiple loops over here. So you can appreciate this is a midesophageal long axis view. So the leaflet that you see over here, it is your A2, and this is your P2. You can see there is a flail of your leaflet, and you can also appreciate that the jet is towards your normal mitral valve leaflet. That is your unaffected mitral valve leaflet, is better to say. Same patients. I have just put the image from your midesophageal commissural view. Now you can see there is a flail segment, and your Cody you can see over here. What are the segments that we are able to see over here? There's P3, A2, and P1. So in P1, if appears to be normal, but you cannot see P2 over here, but you can see the tip of the P2 over here. So in this view, you can appreciate that the P1 remains normal. But if we put 3D, you can appreciate over here The problem is both with P1 and P2. You can see this is your tip of your Cody, ruptured Cody. This is a 3D en-face view of a same patient. Now next patients. This is also midesophageal long axis view. You can also appreciate over here, there is this is A2, this is also P2. You can see the P2 is also flail. You can see, appreciate the tip of your scallop and also towards your LA. And ruptured Cody you can see in the LA. You put the colored Doppler, you can see nice piece of formation and also this wall hugging jet towards your anterior mitral leaflet. That means towards your unaffected leaflet. So this is a severe MR as it is a wall hugging jet and also this is a flail. So this is the same patient. You are seeing it from your midesophageal commissural view. Now here you can see also there is a hood like P2. You can see over here behind A2. This is your P1 and this is your P2. You can see over your A2 scallop. You put colored Doppler over here. You can see the jet is above your A2 segment. Now you can see this is the P2 segment and you can also appreciate the ruptured Cody. Now can you appreciate the 2D examination of this valve? You can see the leaflet is thickened. But can you tell me is it calcified? No, it is not calcified. It is thickened. So there is a myxomatous degeneration. This is a myxomatous degeneration of your posterior mitral leaflet. And also there is a myxomatous degeneration as well at the tip of your anterior mitral leaflet. So what is the view? We can see over here. This is a LVOT we can see. So, but we cannot see any aortic valve. So it is anywhere between your midesophageal 5 chamber and your 4 chamber. So it can be A2, P2 or it can be also A1, P1. So mainly P1 or P2 is your culprit. So you can see over the colored Doppler, put the colored Doppler in the same image. You can see over your eccentric jet. Now this is your midesophageal long axis view. You can see there is a P2 and there is also A2. And at the end of the loop, you can see there is a ruptured Cody also. This is a, now in this image, you can see the leaflet. This is a, what is the view? Midesophageal 5 chamber view. You can see there is a P1. So this has to be P1. And you can also see this shiny dot. This is a flailed Cody. You can also appreciate your wall hugging jet over your A1. Same patient, midesophageal commissural view. So this is A2. A2 is unaffected. You can appreciate that. Same patient in your mid-esophageal long axis view. Now we can see a beautiful thing in this color Doppler. Can you appreciate? If it would have been A2 lesion, this jet would have been continuous. So there is a discontinuation between these two jet. Can you appreciate that? So this jet is coming from a different direction, probably. So in these things, your 3D will give you a better insight. This is your 3D. What are the things you can see? You can see there is a A1, this was your, sorry, let me go through. So you can appreciate over here, this is a P1, P1 flail, and also there is a prolapse of your P2, P3 junction. This is another 5-chamber view. You can see the prolapse of your leaflet, anterior mitral leaflet, and also there is a restriction of your posterior mitral leaflet. Now, the same image in the 5-chamber view, you can appreciate the flail segment, that is your A1. Same patient in a 4-chamber view, can you appreciate, is there, if there is no flail segment? That means this you are dealing with your A2 and P2. And also you can see this jet origin is not from this one. So it is a discontinuous thing. So whatever seeing the colored aliasing that you are seeing over here, it is not originating from exactly from this orifice. Now can you appreciate over here? So there is a problem in A1 P1 region. So this is your P1. This is your 3D. So this is your prolapse of your A1 P1. Can you appreciate over here? Now this is another. This is a 4-chamber view. You can also see the myxomatous degeneration of your anterior mitral leaflet and also its flail over your posterior mitral leaflet. So it's a Carpentier type 2 lesion. Flow is directed away from your affected leaflet. This is your commissural view. And this is your 2-chamber view. Sorry, this is a commissural view. Now you can see this is your 3D. Why 3D is important? This is a myxomatous degeneration of your anterior mitral leaflet, and also this flail chordae that was not evident in your 2D examination. It covers your A2 segment and A3 segment. Sorry, A1 segment. Now this leaflet, you can see the tip is thickened and it's also has a rolled edge. But there is no coaptation gap per se. There is movement is also appears to be normal. But when you put the colored Doppler, you can see over here, there is a flow occurring through this body of this leaflet. So this must be your any perforation or cleft you are dealing with. This is commissural view. What is this junction? It is around A2P3 area, somewhere in between. So there must be a cleft in there. So this is a coaptation between anterior mitral leaflet and your posterior mitral leaflet. Now this is your 3D. Now you are very much sure that this is your cleft between your A2 and A3. You can appreciate the cleft over here. Now you can know that cleft, there is no indentation actually in the anterior mitral leaflet. So if there is any indentation like thing is occurring in your anterior mitral leaflet, it is to be considered as a cleft. But in case of your posterior mitral leaflet, it has to be, while telling you which one is cleft, it has to be more than 50% of your width. Now can you appreciate the movement? It has decreased. It is a decreased movement. So that means it is a Carpentier type 3 you're dealing with. You put color Doppler, you can see there is a flow acceleration, and there is a flow acceleration both during systole and diastole. The patient is also having both MS and MR. That is the basic thing you can tell over this. Now, while 3D, this is a rheumatic pathology. You can see lots of calcification and also thickening of your leaflets. Leaflet has become heavy. This is from your LA side and this is from your LV side. We are seeing. Now we can see this is also a restricted leaflet. The PML is not moving at all. AML is moving, but it is unable to cover it up completely. So there is a coaptation gap, visible coaptation gap in 2D examination. You can see, put color Doppler. The color scale is 56. You can see a nice piece of formation over here. And you can see a torrential jet of your MR. So this is a rheumatic mitral regurgitation that you are dealing with. So this is a 3D of the valve. You can see even in this is a coaptation gap that you are able to see even when the valve is closing. Now you can see there is a nice piece of formation in the mediasophageal fourth chamber. This is another patient, not the same patient. While seeing the PISA, it might look like the patient is having mild MS or moderate MS. But while putting the continuous wave Doppler, you can appreciate over here, there is a distinct E and A component of your waveform. That means the patient is not in atrial fibrillation. Patient's heart rate is around 93. You can see over this image. And also, you can appreciate the entire waveform has been traced, and you can appreciate the mean pressure gradient is 14. So I have to examine further. Now you can appreciate there is a fusion of your posteromedial commissure. So that means this is a severe mitral stenosis that you are dealing with. Now look at this image. Look at the size of the LV. It is enlarged, right? And also there is a distinct wall motion abnormality. There is a reduced mobility. There is a gross hypokinesia that you can see over here, and you can see the mitral valve leaflet. Now you have put colored Doppler and enlarged it. You are seeing this image. Do you think it is a severe MR? Let's see. Now remember one thing, that you are seeing it at a 46 Nyquist limit. So it appears to be a severe MR. Now let us see. Whenever the same patient, we have measured the PISA radius. It is 0.5 centimeter. And the same patient, we have traced the that is continuous wave Doppler waveform of your MR, and your ERO has come between 0.17 centimeter square. Now to remember, EROA, if it is more than 0.4, that is severe MR in case of your primary MR. But if the ERO is more than 0.2 centimeter square in case of secondary MR, that is considered to be severe. But currently in European guideline, they have told that ERO has to be 0.4 for both primary and your secondary MR. Now you can see the leaflet is actually moving less. It is restricted movement. So this is a Carpentier type 3. Similar kind of patient. Now you can see over here the scale is 56. Now let us see. Now its MR radius is 0.7 and your MR Vmax is 434. So MR ERO has come 0.33. So this is a severe secondary MR that you are dealing with. So these are my references. Thank you.
Thank you so much, Abhinandan. Any question? Any chat? No, there is no questions in the chat box also.
Okay.
So, so as we conclude, let us remember that the T is not just about the acquiring images,
Yes.
but it is about the understanding of the heart and in its most dynamic form. Isn't it right, Dr.
Yes,
Abhinandan?
ma'am. Yes, ma'am.
Yes, the more we learn to see, the more we can learn to face life. So this basic classes and basic knowledge about the transesophageal cardiography is very important to all of us. So thank you, Dr. Abhinandan, for the excellent presentation, and thank
There
you,
is a one
everyone.
question. How to diagnose a restriction of one leaflet and with frail and prolapse of another? Oh, there is a complex pathology. If your restriction of one leaflet, that means the more you see your normal valve, you will be able to understand which is a normal movement of one leaflet and which is a restricted movement. If your leaflet is not coming at your annular level, it is at the end of your diastole, and if it is not opening completely at the opening of your at the opening of your systole, that means it is a restricted one. And also you have to remember, if there is any flail or prolapse of another, you are actually comparing it with the other leaflet, right? So it is also very much dicey to say whether the one leaflet is restricted and one leaflet is more mobile. Is more you see the normal one, more you understand which is the normal one. So I will advise every one of you to look the normal one more and more. That's how you will understand. Your eyes will get trained like that. That this is a not a normal. This is the restricted one. It is a very pertinent question, because many a times if one leaflet is flail and it looks like the other leaflet is not moving, so it may appear as that another other leaflet is actually restricted, but it may or may not. So it's better to say that it's more you see, more you train your eyes, that will be your pertinent answer. And also remember, while doing your 2D examination, if you see there is any thickening of your leaflet, if there is any caudal calcification, if there is any calcification of your annulus of that particular leaflet, that means that leaflet is likely to be less mobile. So it is not a particular view that is important. You have to see the all the images. You have to understand how the pathology, how the physiology is being done. Sorry, how the leaflet dynamics are actually moving.
Yes, that's very true. That before coming to a conclusion, we have to see all the images of that
Mhm.
particular structures. Before, just we cannot see one image and then we conclude into the decision. But it should be given after seeing all the images, because it
Yes,
can
yes,
be it can be normal in other images, and that might be an artifact.
yes, yes, ma'am.
So
And
so
also,
in the
we are
next.
dealing with your pathological heart. So it is not possible a particular omniplane angle we will be seeing only at particular scallops only. So we have to keep on rotating in every possible angle so that we can understand more and more about the valve.
Okay, so then the next class we'll be going
We'll be
to learn.
discussing about tricuspid and aortic, ma'am.
Okay, okay. So for the so we are hoping to hear the excellent lecture again in our next class.
Okay.
So uh, so always keep your heart beating and be with the heart lines. So thank you very much for participating in the class, and expect all of you a very good evening, and thank you so much.
Thank you, ma'am. Thank you, everyone.